First of all, I want to thank Veena Undavali and Sai Undavali for giving this platform, along with Rama and her team for interacting with you today. It's quite nostalgic for me here because I'm a product of Osmania University. Way back 78 and 79, I joined medical school, Osmania Medical College here. I want to tell you that I graduated from Osmania Medical College with a cost of 470 rupees. That's all I have spent to become a medical graduate. This country has given me so much. And then the second nostalgic thing for me here is we are in the auditorium named after Professor G. Ram Reddy. I had quite a bit close interaction with him. His son was my colleague, and we used to regularly interact with Professor Ram Reddy Garu during his UGC days and then the district education, because he's the Karta of district education in our country. So, given that background, I will start my journey of running the NICE Foundation for the last almost 2.5 decades. A situation took me way back in 90s to the tribal regions of our state, the combined state, Andhra Pradesh, the region called the Paderu. Our sister organization was working with the tribals in that region. So, knowing my background of being a neonatologist, I was working in the corporate world at that point of time. The CEO of the foundation, the Nandi Foundation, asked me to visit the region and then come out with a solution for the tribals in healthcare. India is a country of numbers, as you know, and we spend very little on health. And that also, we are running programs which are not giving the optimal results. Given that background, I, as a professional neonatologist, my business was saving newborn life. We were feeling very proud that saving 800 grandma in the ICU, we used to think that we are next to God. In that background, I had gone to the tribal regions almost 25 years back. No roads, no electricity. When I looked at everything was a chaos there. So given that, I wanted to do a bit of survey to understand the population need and necessity of healthcare intervention. So I told my team that let me visit some villages. I want to interact with the communities. So when I started listening to them, the typical story was a young girl, because at the point of time, childhood marriages were the rule of the day. Young girl gets married, and then 16 or 17, she becomes pregnant, and then no antenatal care, and 9 months journey goes on, and then the D-Day comes where the labor pains start, and that she has no clue what is in store for her. The only available resource for her is a traditional healer in the village. And this traditional healer tries all sorts of things, from doing rituals, pouring hot oil or hot water on the abdomen, belly, doing massage, you name it, scarring the belly line. Every possible criminal activity is done on to that pregnant woman. And after all that, she gives up and says, I can't do anything, you need to take her to a healthcare facility. Most of the time, it's on a rainy day or in the middle of a night. And this woman will be carried by 4 able men of the village on a thing called Joli. And then the distance to the nearest healthcare facility will be anything between 2 to 4 hours. Imagine the plight of that pregnant girl in active labor, going through the pain and not knowing where she is going. Most of the time, every village had a story which the woman gave up midway, means to say we lost the expectant mother. Some of them lost their babies. Some of them who were made to the healthcare facility are told nobody is available. You need to go to a higher center. And some of them came back into the village and landed up into trouble. Every village had a story like that within 5 years of the tenure which I visited. When we interacted with husbands, we found some husbands who lost women. See, normally the tradition in that culture is that if a wife dies, he marries the younger girl, the sister of the deceased. Some husbands lost both wives. So that's the story I got into at that point of time. Things have changed now, but that was the background. Here I was working in an ICU, trying to save newborn lives and feeling that I am doing the ultimate. And then here the situation was something completely different. That was the time I made my decision of changing my direction from the ICU, the comfort of an ICU, into the remote regions of the country. India spends very little money on health, and certain sections of the society have not took the benefit of the advances which we are making. We may be economically improving, healthcare may be accessible to certain urban and semi-urban areas, but when it comes to tribal regions, it is inaccessible. So we took that journey of trying to address the needs of the deserving or the neglected sections of the society. That's how our journey of NICE Foundation started. I'll run through some of the slides. This is how the woman is carried on a jolly to the nearest healthcare facility. Even today, this happens. This picture was taken 1.5 years back. A woman crossing the stream in active labor, carried by women. And then a jolly where more able people are taking her to the nearest healthcare facility. So given this background, we came out with a model where we identified educated, sometimes qualified nurses from the region, skilled them up to the need and necessity of the time, and then employed them and started the service called a fixed day service. So every tribal village, we run a clinic 2 hours every week once. Some regions we visit twice a week. So as to, we have trained them in safe delivery procedures, bringing them to Hyderabad in our facility in Hyderabad, skilling them, making them able, capable, and then putting them back there. There are some roads where they can go on 2-wheelers, 4-wheelers, and there are kacha roads they need to travel. After that, the ritual starts. These are my team members. This is happening in the present seasons also. This is not an old picture. This is the last year's picture, last season. And we, irrespective of the situation, whether it is a holiday, monsoon day, curfew day, we run our clinics on the stipulated time in these regions. That's how we got the confidence of the communities. The moment we reach, our team reaches, the community comes and for the services. Antenatal care happens. And then some women who don't come to the facility, we go to their village or to their houses and then examine their babies and then themselves, checking their weights. And then everybody's needs are addressed as far as healthcare is concerned. This is the last mile healthcare delivery model. Children, women, and in every village there are some women who are bedridden. Even in the small hamlets, 1 or 2 women are bedridden. We, after running the clinic at a stipulated place, my team members go to the village and do provide the service at the doorstep. Not only that, we have also taken on a path of empowering the community through the activity of PLA, participatory learning and action. We understand their problems and make themselves come out with a solution and see that they follow that solution uniformly. This is one such activity in a tribal region called Mananur Forest in Telangana. And then we also do PDG activity, participatory discussion group activity, wherein expected women and then lifestyle disease patients are educated on their problem to address their problems. After coming this far, we found that there is a need to build the capability of the traditional healers whose the community has confidence in. So we built up a capabilities of the traditional birth attendants through a program called TBA training program, wherein they are trained how to resuscitate a newborn, how to conduct a clean delivery. This is one such training module. So you can see the confidence of a tribal resuscitating a newborn. Obviously it's a mannequin which she's experimenting on. Even my neonatal unit fellows, I don't see that much amount of confidence when they are resuscitating a baby. You can look at the smile and the confidence and then with which the posture she is able to handle the prospective newborn. That is the tribal program which we are running. We are running in 864 villages in 5 states in the country at this point of time. Then the next program of ours was school healthcare program. In our country, the poorest of the poor send their children to the government school. Even if you have little bit of money, you send them to a private school. Only children whose parents cannot afford anything send their children to government schools. For me, he's the first citizen of the country. The child who is accessing the government school is the first citizen of the country. I'll tell you why. He would not have eaten that day because we have done a study. 14% of government school accessing children in Hyderabad 10 years back, the midday meal was the first meal. In a city like Hyderabad, we are working in 256 government schools in Badarpura, Bandlaguda, Asif Nagar, Sheikpet and Golconda schools. This is the statistics. I don't think it has changed much even now. So this child, parents not educated, there are no books much, no clothing much, stomach empty, and then he is going to a school which may not be functioning well, teacher may not be coming well. In spite of all these compromises, this child is accessing the school to become himself an educated citizen of our country. We need to support this sort of a citizen. That's the reason why I say the first citizen of the country is the government school accessing child. So this program we started as a school healthcare model, which we implemented in Hyderabad and went to Rajasthan. And then after our success story, 11th 5-year plan of the country took up this model as a model for the country. So these are some of the pictures of the school healthcare intervention program which we are running now. We also try to educate children because we found that educating a children is like educating the family. So all the basic habits and clean hygienic methods of living are educated to these children. Hand washing, this we started much before COVID. So it was helpful for us. These are all before COVID. And we also use transit walks in the village on a World Health Day. Those sort of activities we entertain and educate the communities through children. And then about the nutrition. Today's world, as you know, educated, uneducated, rich, poor, what we are eating is not appropriate. There is a need to eat the right kind of food. So we take efforts to see that these children are educated on the best habits of eating. And then this again, hand wash. In this background came the COVID. So we were working in tribal regions. We are working in Domriguda, Ukumpeta, Munchingmut, Anantagiri, Chintapalli, Jima, Adugula, Araku and Paderu mandals of Vishakhapatnam. We are working for the last 20 years now. So we found that we were the only support for them during this period. And then quickly, within 2 weeks' time, we turned around. We built the capabilities of ASHA workers in villages where there was an ASHA worker. if there was no ASHA worker, an educated girl, we trained them through our online training platform module, how to record a temperature, and then how to do the pulse oximetry, and then whoever is having temperature or a low saturations were again confirmed through a the rapid antigen test, and then if they are found positive, we were giving the drugs. This we effectively ran for 2.5 months in this period, in that period where there was no way there was any access to healthcare in these regions. 1,800 villages we covered during that time. 28 patients were positive, were moved to institutions. All of them have come back to their villages. And then we also promoted the vaccine uptake in these communities. This is all because the time was short. I didn't want to take. We are doing many more projects. In projects we do cluster randomized trials in the field, and then we are also doing different templates. They call the CHIP Community Health Intervention Program, and then of late we have graduated to a program called Adarsha Gramam, where the focus is on pre-primary care. India is a country of numbers, and then we may be having the maximum number of young population in the world, but we also are known for the diabetes capital of the world, and we are also very soon will be known as the cancer capital of the world. There is a need to create awareness in the community in terms of eating habits, in terms of lifestyle diseases, and in terms of cancer detection, and then further care. We are on that journey, and then the idea is to create new templates, ask the stakeholders to take it further. That's the principle of our organization. Thank you.